In these lectures, I'm going to focus on assessing cognitive impairments. Just to remind ourselves, cognitive impairments are most pronounced in right hemisphere damage compared to left hemisphere damage. They're more apparent in traumatic brain injury and dementia. Even mild cognitive impairments are important to address. Cognitive impairments can affect how well patients respond in their other rehabilitation endeavors, physical therapy, occupational therapy, etc. And it's also important for us to understand the range or the kinds of cognitive impairments that patients have, because most of our treatment for individuals with cognitive impairments, whether they be attention, memory, executive function, really focus on compensatory strategies. And in a way, I don't think these are, in a sense, they're not really compensatory, a lot of them. The reason I say that is because these are often strategies we teach people that we ourselves use. I use a calendar and a to-do application to help me manage the things that I have to do. All kinds of behaviors, both overt, like using an application, and more covert, the things that I do in my mind to help myself remember something that I'm learning, etc. These are behaviors that, for one reason or another, people with right hemisphere damage, TBI, dementia, they're not practicing them anymore. And because of their difficulties, they need them even more. But as you can imagine, having memory impairments might interact with your ability to remember to engage in a strategy, etc. So you can see here that it can get a bit complex, but the more we understand about our patient, the more likely we are to, with the patient, come up with a good solution. Anosognosia, deficit awareness, is one of these cognitive impairments that is it's a foundation. It's a foundational ability, right? If one doesn't have awareness that they have a problem, well, they're not going to be motivated for treatment. They're not going to be intellectually engaged. They may not learn very well. They won't implement the strategies, etc. And so that's kind of something at baseline that patients need to have, and it's deficit awareness is often a problem in TBI, right hemisphere disorder, and dementia. We need to remember that any language problems can interfere with the validity of a test result if a cognitive test, and many cognitive tests do, if the test relies on language skills. Even motor speech problems, an apraxia of speech, or a spastic dysarthria where speech is slow, can affect the scores that people will get on some cognitive tests, particularly tests that are speed tests where you need to respond verbally within a certain amount of time or as fast as you can. In general, to be real, many of the tests described in your book and the tests that I will go over here, although I tried to focus mostly on, I think, the ones that are most commonly given in speech pathology clinical practice based on my experience and what I see in the speech pathology treatment literature. That we don't have time to give these complete test batteries We may be able to get portions of them, and our observations of patients and understanding what their goals are will help us choose the right portions to give. But again, I want to reiterate that we can understand a lot about our patients by observing them. Not only observing them in our office during testing, but in other settings and contexts, if possible. And of course, caregivers are also a valuable asset, although we always have to remember that caregivers, for whatever reason, can also be somewhat distorted in their perception of what a person's problems are. But in general, my sense is that you can tell when caregivers are being reasonable and fairly accurate, mostly because they line up with what you're seeing.